My name is Haifa Kathrin Al-Ali. I'm a hemato-oncologist working at the University Hospital of Halle in Germany. And today we are at the EHA 2024 in Madrid. And I would like very much to speak to you about how to improve the management of patients with PV. And the question is, are we really doing enough? I think we all agree that in the last few years, a lot of things have very much improved. But there are still some issues and some room of improvement. First of all, what about our risk stratification for thromboembolic events? We know all that thromboembolic events is one of the major causes of morbidity and mortality for patients with PV. And according to our traditional, conventional risk stratification, we consider age above 60, as well as thromboembolic events. And the question is, are these two risk factors of equal weight? We have very nice data coming from the United States showing very clearly that this is not the case. Thromboembolic events are much more relevant as a risk factor for a further and a second thromboembolic event for patients with PV compared to age alone. So we have to rethink our classification. Second, what about CHIP-associated somatic mutations like ASXL1? We know very well that CHIP has been long well known by cardiologists that it is associated with the risk of cardiovascular disease. And we have very nice data showing that if we incorporate CHIP-associated mutations in our risk stratification, in addition to cardiovascular risk factors and the presence of thromboembolic events, that we could almost reclassify all our so-called high-risk patients based on age alone. Because if I have an elderly patient with no cardiovascular risk factor, with no mutation, CHIP mutation, and no thromboembolic event, then this patient is actually a low-risk patient and very low probability of getting a thromboembolic event in the next few years. Finally, I think it is also very, very important to think about machine learning as a new way to better identify patients at high risk of thromboembolic events. For example, the PVA trial has shown us that, for example, a high neutrophil percentage or a low lymphocyte percentage and certain values for the red cell distribution rate could be all very, very relevant, simple parameters to identify patients at high risk of thrombosis. So I think we have to rethink risk stratification. This is just one aspect of the management of PV, but what about symptoms? We all know that symptoms are very abundant in patients with PV with a negative impact on the quality of life. We, as I said, are having a lot of improvement with the TSS and stuff like that, but I think there is still a very big lack of alignment between what we as physicians perceive and what patients perceive. And the goals of treatment do differ between patients and physicians, and we have to become better there. Further, are we doing enough in cardiovascular risk assessment? I think no. There is still room for improvement, and Claire Harrison and her team have presented last EHA very nice data showing that around 80% of patients and doctors are doing a screening for cardiovascular risk disease, but the 20% of doctors who do not do this, that there is no need, no resources, and no time. And again, the perception of patients is completely different, as patients state that only 55% of them receive cardiovascular risk factors assessment. So again, there is room for improvement. And I think finally, we have to really be very careful about signs of progression. We have very nice data showing, for example, progressive leukocytosis as a relevant risk factor for disease progression, as well as the presence of a thromboembolic event. So again, we have to pay more attention to that. And finally, I think we have to do much more active screening for secondary cancers in patients with PV, as we know very well that 1/3 of these patients do have second cancers in the course of their disease, mainly non-melanoma skin cancer, but also hematological malignancies like secondary myelofibrosis, leukemic transformation, but also all other solid tumors. So active surveillance is really needed. And again, there is room for improvement. So in summary, I think we have achieved a lot. but I think we still have some way to go to further improve the outcome of our patients, to more individualize our approach in the treatment of each individual patient with PV. And with this, I would like to thank you very much. Thank you.